Hello everyone, my name is Gautam Vidadi. I'm the Director of Cardiac Services and Cardiologist at Cabrini Health. I'm also the Head of the Heart Failure Services at Northern Health. The COVID-19 pandemic, I think, has proven challenging to organise teaching for medical students, and so I thought I'd take the opportunity to put together some video presentations that might help you in your learning. What I wanted to do was to use some ECGs to help with teaching, and in particular put the ECG out there and then present you with some clinical scenarios to help you interpret the ECG in that particular clinical context. This is my first presentation like this, so I'd appreciate some feedback and hope to do more over time. So here's a ECG demonstrating a typical left bundle branch block. You can see that the ECG is in sinus rhythm. It's a regular rhythm. There's a broad QRS complex with an M pattern in 1 AVL and lead V6, which is typical. I'm not intending to go through all the variants of left bundle branch block and typical ECG features. I'd sort of refer you at this stage to ECG Made Easy or Marriott's Practical Electrocardiography to help with that. But have this ECG imprinted in your mind, and let's start with the first case. So here's a 68-year-old chap with chest pain presenting with typical central chest pain. Has a risk factors for heart disease including hypertension and type 2 diabetes. Blood pressure is 100 on 60. Saturations are pretty good at 95%, but looks a bit pale and sweaty. So what's the differential diagnosis here? Well, anyone who's presenting with acute chest pain to an emergency department, you want to be trying to rule out life-threatening conditions. So in this setting, is he having a heart attack or myocardial infarct? Is this a pulmonary embolism? Or could this be aortic dissection? These are some of those critical conditions that must be excluded. Now at the moment, chest pain, central, in a man with risk factors for heart disease, looking pale and sweaty, certainly infarction is at the top of the list. His oxygen saturations are not low, making pulmonary embolism less likely. Aortic dissection is notoriously difficult to diagnose and often missed, so you might pick this up with a chest x-ray that suggests a widened mediastinum, for example. But we'll talk about aortic dissection a little bit further in some separate talks. So top of this list is whether he is having a myocardial infarct. Now traditionally we look for ST elevation as a determinant of whether somebody needs to go to the cath lab, but as you'd be aware, left bundle branch block is often taken to be the equivalent of a ST elevation myocardial infarct when somebody presents with typical chest pain. So the really useful thing here would be whether there is an ECG to compare to. Sometimes we have this available and sometimes we don't, and what we're trying to decide then is whether this left bundle branch block is new or old. Often in the reality is that it's difficult to get access to those ECGs in a timely manner, and if you don't, you'll just have to assume that this is new left bundle branch block with typical chest pain. You don't usually have blood tests available rapidly, although some places will have point of care troponin assays, but really the decision whether this patient needs to go to the cath lab for urgent angiography is based on a clinical assessment of their chest pain and interpretation of the ECG. So in this scenario, we would assume that this is an ST elevation myocardial infarct equivalent based on the left bundle branch block ECG. And usually these patients are quite sick, become quite unstable, and to be able to cause a left bundle branch block usually need quite a large infarct, which usually involves the left anterior descending artery or anterior myocardial wall. Okay, so let's have a look at another case. So, 68-year-old man, this could be the same patient, but this time having a blackout while driving the car. Again, the ECG is exactly the same. It's a left bundle branch block. So he's driving on a local road, heading to work, feels quite well, and then finds himself crashed into a parked car at low speed of about 40 kilometers an hour. He has no recollection of what's happened. Has a past history of hypertension, is normally fit and quite well, just treated with amlodipine. And that's the ECG that you've got, left bundle branch block. So let's assume that his blood tests are completely normal. So a blackout while driving the car raises a few possibilities. Number one is does this represent syncope? So syncope is a transient loss of consciousness caused by a reduction in cerebral blood flow that's rapidly reversible with minimal intervention. Causes of syncope include hypotension, which could be due to things like a fainting spell or vasovagal event. Could be due to some sort of cardiac etiology, such as an arrhythmia or bradycardic event, such as heart block, for example, which could be transient, or a malignant arrhythmia, such as ventricular tachycardia, for example. Other possible causes of a loss of consciousness while driving, which is what we presume this is, include a neurologic event, such as a seizure disorder, and of course, you can think about other things such as subarachnoid hemorrhage, and this sort of patient would undergo a toxicology screen looking for alcohol, drug use, and sometimes patients can, of course, fall asleep at the wheel and be unaware of what's happened. Does he have a history of sleep apnea or risk factors for sleep apnea, for example? Again, we sort of come back to the ECG. So the ECG is abnormal, and the left bundle branch block can imply underlying heart disease. So the left bundle branch block could suggest myocardial infarction, as we saw before, but it also suggests underlying conduction system disease because the left bundle is blocked or not working properly. So the take-home message here is that the abnormal ECG itself predicts a very high likelihood that this gentleman has underlying cardiac disease. It also predicts a much higher likelihood that this episode of altered conscious state is much more likely to be arrhythmic, including things like complete heart block, and therefore requires a lot more cardiac investigation. That would include, for example, an echocardiogram to assess cardiac structure and function, a Holter monitor, or in this case really admission to hospital for at least 24 hours of cardiac monitoring to see if you can pick up an arrhythmia. And studies suggest that in people who are really well and assuming that his heart function is normal, who have an altered conscious state or episode of syncope with left bundle branch block, probably 50% of them may have an arrhythmic cause. So sometimes we end up implanting a loop recorder long term to monitor their heart rhythm and try to pick up evidence of bradycardia or asystole that could be causing syncope. So a very different interpretation of this ECG in this clinical context, and yet the ECG is the same. Let's go on to the third case. So here's a 55-year-old woman who's come in for a routine health check to her primary care physician. She's fit and well, goes to the gym regularly, has no symptoms, no medical problems, on no medication, but her ECG shows a left bundle branch block. Well, this is again a completely different clinical scenario to what we saw before. So left bundle branch block can occur as part of just degeneration of the conducting system that can occur over time, and there are many people that can have a left bundle branch block and be completely asymptomatic, but it can also be a predictor of underlying heart disease. So almost any significant heart disease, whether it's heart failure and left ventricular dysfunction, whether it's ischemic heart disease, for example, can all cause a left bundle branch block. So in an asymptomatic patient, it would probably be reasonable at minimum to get an echocardiogram to make sure that cardiac structure and function is normal. But I think at that point, if the patient has no risk factors for heart disease and all of those have been assessed, no family history, no symptoms, is fit and active with a normal echocardiogram, then no further investigations would be warranted. But it would be important that the patient's aware that this is their ECG and there is a small probability of progression in conduction system disease over time, but it's not possible to actually predict that. Let's go to the last case, which is a 75-year-old woman who presents with shortness of breath on exertion. So this lady again has the same ECG, sinus rhythm, left bundle branch block, but a 4-month history of exertional dyspnea. She has a past history of stage 3 chronic kidney disease, type 2 diabetes, hypertension and gout, and is on perindopril 2 milligrams daily, some linagliptin, aspirin, amlodipine and atorvastatin. So same ECG, but now presenting with shortness of breath in a patient who's really multimorbid in terms of their diseases. So just looking at the risk factors, kidney disease, hypertension and diabetes, the probability of underlying heart disease, either heart failure or ischemic heart disease, is high. Now this lady also has symptoms. She's breathless on exertion. So in this context, a left bundle branch block predicts a very high chance of underlying heart disease as a driver. And the number 1 and 2 things that you'd be looking for is, does this patient have undiagnosed significant obstructive coronary artery disease causing ischemia, or does this patient have heart failure? And the key tests that would help in assessing this would be an echocardiogram to assess for left ventricular systolic dysfunction or diastolic dysfunction, and a functional study, most likely, to look for inducible ischemia. So by functional study, I mean some form of stress testing. Now with a left bundle branch block, exercise testing is difficult to interpret because the ECG is hard to interpret and you get abnormal movement of the myocardial septum during left bundle branch block, making imaging with echocardiography difficult. So a pharmacologic nuclear perfusion study is probably the most appropriate test to look for ischemia as a cause of shortness of breath in this clinical scenario. And in some situations like this, one might even consider angiography, but you would need to be very careful because of this lady's stage 3 chronic kidney disease and the risk of the dye that we use for the angiogram causing further renal dysfunction. But in essence, the left bundle branch block in this situation adds substantial additional weight to a cardiac etiology for her symptoms. All right, I'm going to sign off now. Thank you very much for listening. Please email me back some feedback and look forward to producing more. Thank you.